Gastro-oesophageal cancer is stomach cancer, but it is a distinction between cancer of the esophagus, which is from the mouth to the stomach, and the stomach itself. So effectively it's a cancer from around this point in the body, there, all around to the stomach area. So if you think in terms of symptoms of stomach cancer, it's a vital organ in terms of when we eat. So if you have a tumour, a small tumour, you may have no symptoms in it. As that tumour, of course, gets bigger, one of the things that can happen is you get fullness early. You may get nausea and vomiting. It's an organ that's crucial for that. And it's possible to get pain, but less likely. Sometimes the tumour can bleed, and that bleeding can go up, and you cough it up, or more likely it comes down through the bottom end, by which times when it comes down the bottom end here, it's black, because it's darkened, it's iron, and it comes out black. If the cancer is spread to other organs, such as the liver here, which is the commonest place for it to go, or the lymph glands around it, then you can get two other forms of symptoms. One is you get loss of appetite, loss of weight, and because you're not eating as much, that ends up leading to a gaunt face, as opposed to a nice firm, full face. And then if you can get fluid distributed in the abdominal cavity, if it spreads within there. The Integrate 2 study is a randomised trial where we offer patients, or we distribute or assign patients to receiving a drug called regorafenib or placebo. And the chances of getting the drug are 2 to 1. So you get a 2/3 chance of getting the drug and a 1/3 chance of getting the placebo, but you won't know what you're getting, and nor will we know either, because the patients are allocated by a computer by number. What we hope to achieve with the Integrate 2 trial is to demonstrate that regorafenib will improve patient survival in the circumstance in which we're giving them the treatment. In addition, we hope that their quality of life will be not affected poorly, or in fact will be improved by doing the treatment. What I mean by that is, if there are some side effects of the drug, then the benefit outweighs the side effects. And finally, it may even improve some of the symptoms of the disease if some patients' tumours marginally shrink as a result of the treatment. One of the advantages of going on a trial, whether a drug works or not, is the degree of scrutiny and support you get on the trial. And there have been studies that have looked at patients in a clinical trial circumstance compared to comparable groups outside the trial, and even found that those patients on the trial who may not have been getting the new treatment do better than they would have done outside of the trial. And we think the reason for that is because of the very close monitoring of the patient that's undertaken. There are more frequent clinic visits in order to make sure, one, that the new treatment we're trying to test is not causing any problems, and two, if there are problems, that we deal with them very quickly, and so, as such, that even the symptoms of the cancer get dealt with much faster. So most patients on a trial will have their own nurse attached to them, a trials nurse or a data manager attached to their care. They'll have frequent fixed visits, even if they're feeling well, which allows us to monitor or preempt things that could be going wrong and then deal with them very quickly. So independent of whether the treatment's finally proven to be as advantageous as we hope it is, their outcomes should be better on the trial, even just compared to standard of care.